Okay, well, students, welcome to our lab on clinical application for the skull. We're going to begin the osseous system, excuse me, and we begin with the skull. Here you can see the human skull. We're going to look at a few different things here. We're going to begin with looking at some of the bones. For example, this bone that you see right here, I don't know why it did that, this bone is known as the frontal bone. You can see it right here. We have one of them in the human, and it's a very large bone. It has a number of different structures. If we want to separate it from the skull and look at it, there are a number of different structures that we can see on the frontal bone itself. One of the things is we can see this. This is the orbital margin, the margin of the orbit. That is to say, we see that there's actually a margin or an edge to the orbit itself. We can also see that there is a notch. Now I'm going to try, if I can here, to move this into a position so it's a little bit easier for you to see. So if we look at this, particular, if we look at the skull, what we want to look at for just a second is how the skull is actually, how the frontal bone is associated with this part of the skull. So bear with me for a second. I need to move just one thing here. Wow, that's not what I wanted to do. There we go. Now when we look at this, here's the frontal bone. Notice that when we look at this frontal bone and we separate it, we can see a couple things. For example, here we have what are known as, these are the supraciliary ridges, sometimes a supraorbital ridge. So guys, it's just a ridge above the orbit, okay? Kind of where your eyebrows would be. But if you notice, there's a hole right here. And in anatomy, a round or oval opening through a bone is known as a foramen. And you can see there's a foramen here. And there's a foramen here. So kind of in a vertical line, there are three foramina. If we look at this frontal bone, we should be able to identify those little holes. When we look at those are known as the supraorbital foramina, or the supraorbital foramen. So you can see it right here. And there are supraorbital nerves that actually go through there and supraorbital vessels. Well, if that's a supraorbital foramen, you can guess what this would be, an infraorbital foramen. Okay, this entire area is known as the orbit. This is the area that the eye resides in. That's known as the orbit. So that's why these are called supra and infraorbital foramen. Now, if that is the case, we should look at one more thing. And keep in mind, there's only one frontal bone in the human. We see a few conditions associated with it. We do have frontal sinuses in here. Also, there's a condition called acromegaly. It's A-C-R-O-M-E-G-A-L-Y, acromegaly. This is a very interesting condition because what we see with acromegaly, it's an endocrine disorder where there's actually what's known as frontal bossing. And that frontal bossing is an expansion of the frontal bone. It actually gets bigger. So we see this frontal bone actually getting larger. So they call it frontal bossing. It's associated with a thing called acromegaly. For example, people like Andre the Giant, if you remember him, a very famous person who suffered from acromegaly. We'll see some more of that later. All right, so that's the frontal bone. Now, if we turn this way, we see there we have this bone. We actually have two of them. These are the parietal bones, one here and one here. So we have one on the left and one on the right. The parietal bones are very interesting, and if you look, you'll see that there is actually a suture. These connective regions are called sutures. We see a suture between the frontal bone and the parietal bone. This is known as the coronal suture. Okay, that's the coronal suture. It's in the coronal plane. There is a point here on the skull where these meet, and you'll see there's a sagittal suture that separates the two parietal bones. So here's the sagittal suture. And then there's this occipital bone right here. And if you look, there's a suture that separates the parietal bone from the occipital bone. This is the lambdoid or lambdoidal suture. Okay, so these are the parietal bones. Now, one important thing to look at here, this region, where you look right where I'm circling, right in this area, you have frontal bone meeting parietal bone, meeting this. This is the temporal bone, and also this, the greater wing of the sphenoid. This region, now this is not a bone, but this region right here is known as the pterion. It's P-T-E-R-I-O-N, the pterion. This particular region is very, very thin, and when injuries occur to that region, there's an excuse me, there's actually an artery deep to this within the cranial vault, and that artery is known as the it's the anterior branch of the middle meningeal artery. And it's possible for a patient to actually have an injury of that, lacerate the artery, and start bleeding into the skull. This is very dangerous. It's an arterial bleed, and they actually suffer from what's known as an epidural hematoma. And this is really critical, and the reason this is critical is there's only so much space in the skull. You only have so much space. You cannot add extra things into the skull. Blood, fluid, masses, tumors. You can't do that because it will cause the brain to undergo compliance or the brain to be injured. The fancy name for that is the Monroe-Kelly doctrine. And that's just a doctrine, if you will, that basically just says, hey, there's only so much space in the skull. And injuries like that are very dangerous because patients may have those, may lose consciousness, and if they do, they may come to again and not really know if they were unconscious, or they may present to the emergency room and have what's known as a lucid interval. This lucid interval, the word lucid means that they are, they are lucid. They comprehend things, they know who they are, where they are, and they'll be speaking to you, and while they speak to you, they'll actually be having blood pile up in the brain, and it will cause the brain eventually to have a herniation, and they potentially just immediately become unconscious and can die right there. So a very, very critical region, very, very critical concept. Okay, so those are parietal bones. I mentioned those two. Now if we spin this around, here's the occipital bone. You have one of them. And very important, you can see this mass right here, this bump. This is known as the EOP, or the external occipital protuberance, sometimes known as the inion, not onion, inion. And that's an area of just and a large area and an expansion. And then if you look extending laterally, and we're going to look at a couple of these individually, extending laterally from this, here's the posterior view, here's the external occipital protuberance, and then you can see the superior nuchal lines extending laterally from it. And then here, if you have a superior nuchal line, you're going to have an inferior nuchal line. And you see it there. This is on the posterior aspect of the occipital bone. These are for muscular attachments. This is also where you see muscles become tight, or what they call nuchal rigidity. I don't know if you've ever heard of that, but it's one of the signs and symptoms often associated with meningitis, a bacterial meningitis. It's what's known as nuchal rigidity. Okay. If you also look at this bone, we flip this up a little bit, and here's a giant hole in it. This is known as the foramen magnum. And obviously, what goes through the foramen magnum would be, at least in part, the spinal cord. Although there are times when part of the spinal cord, any central nervous system tissue that we see anatomically superior or above the foramen magnum, we actually, that's what we define as the brain stem. So, we see that it is possible for parts of the brainstem to be pushed through the foramen magnum. That's known as an Arnold-Chiari malformation, and obviously we cannot compress parts of the brainstem, especially the lower brainstem or medulla. That could be a cause of death. So that can be a very, very serious event. And then associated with that, or around the foramen magnum, we see these two elevations. These are the occipital condyles. This is actually where the occipital bone articulates with your first vertebra, or the C1 vertebra, or the atlas. Obviously very important, not a joint you would want to dislocate. Okay, so there's occipital bone. All right, we want to turn around and look now at temporal bone. We see it here. This is a temporal bone. It has many parts. If we look at the parts, this region, okay guys, this is the zygomatic bone, if you look right here. And then this is the temporal bone. So this part of the temporal bone, right where I'm pointing, is known as the zygomatic process of the temporal bone, whereas this part of the zygomatic bone would be known as the temporal process of the zygomatic bone. So we have temporal process of zygomatic bone here, zygomatic process of temporal bone here. This part of the temporal bone is called the squamous part because it's flat, and that makes this suture between the parietal bone and the temporal bone, this suture is known as the squamous suture. So look at this temporal bone. So we saw here the zygomatic process of temporal bone. Here's the squamous part of temporal bone. We see this, which is we see this hole right here. This is the external acoustic or external auditory meatus, sometimes called, some people call it the ear hole. We would never call it that. And on temporal bone, we have this expansion known as the mastoid process. That mastoid process is a very critical part. Here we see it right here, this mastoid process. Patients should not have pain when you press on their mastoid process. That should not hurt, okay? And sometimes that's used by physicians to determine if a patient is not really being honest about their level of pain, okay? They call it Mankoff's test. It's basically a test to see if a patient is really not being honest. However, it is possible in a kid, if there is pain in that area, this can be very serious because this may be an indication of a mastoiditis or an infection within the mastoid process of temporal bone, and that can be very, very serious. So that can be a very important clinical sign. All right, a couple other things to look at here. On the temporal bone, we're going to look at this again, and here's why. Because when we look at it, we also see this kind of sharp, pencil-like looking object. That's the styloid process of temporal bone. And right between them, there's a hole. So that would be a foramen. We would call that the stylomastoid foramen because it's between styloid and mastoid process. Okay. So if we spin this around now, we're going to see a couple different things. And to do this, I'm going to show you a different view. I'm going to show you a cranial fossa view. All right, and what I'm doing is showing you the skull again. I've just removed the parietal bones. Okay, I have removed the parietal bones here. If you look into the skull, there are really what are known as three cranial fossa. This is considered the anterior cranial fossa, this depression. You see it made mainly of frontal bone. This region here would be considered the middle cranial fossa. So I'm just going to run the pointer over that. This region is middle cranial fossa, and then this region is posterior cranial fossa. So that is to say, it looks like there are three levels, 1, 2, 3 levels within the skull. And you can see here this temporal bone sticks into these cranial fossa. So this is still temporal bone, but it has part that extends inside the cranial vault. This is known as the petrous portion of temporal bone. And yeah, there's a ridge on top of the petrous portion of temporal bone, and as you can probably guess, it's known as the petrous ridge. Okay? This is important. Cranial nerve 6, the abducens nerve, actually runs right along the top of that petrous ridge. So that can be, cranial nerve 6 does, so it can be compressed with pressure on this. This has a hole in it, the internal acoustic meatus, or internal auditory meatus. And guys, within this petrous portion of temporal bone, this is the strongest piece of bone that you have. Within there are your inner ear mechanisms, okay? The inner ear mechanisms of the human. So we're going to isolate this now and look at pieces, spin this around. Now you can see what I'm talking about. Here's the petrous ridge, and that's the petrous ridge. Here's the petrous part of the temporal bone, this whole piece. Here's that internal acoustic meatus. Okay? One more thing to look at here. Notice how the internal acoustic meatus and the external auditory meatus are not the same whole. They are not. If we look here, so let me orient you again. I'm going to remove this. Let me orient you again. There is a depression right here. This bone is the mandible. There's a depression on the temporal bone for the mandible. That depression on the temporal bone for the mandible is known as the mandibular fossa, but it's of the temporal bone. It fits right there. That particular area is very important because when the mandible articulates there, it makes up what's known as the temporomandibular joint. Okay? Sometimes referred to as the TMJ. That joint very commonly can dislocate anteriorly. In other words, when someone opens their mouth or depresses their mandible, this part of the mandible can actually dislocate from that fossa. And we'll talk a little bit about that later. All right, so we've seen that. We've seen a lot of these bones. I do want to mention this bone to you, and this is a difficult one. This is the sphenoid bone. Excuse me, this is a bat-shaped bone. You can see how it kind of looks like a bat. And it makes up part of the orbit, that's true. It makes up the base of the skull. We're going to look at this individually. And when you look at it, it has lots of parts. Here it does look like a bat. So I'm going to position this as if you're looking down into the cranial vault. And if you want to get oriented, you can look at it this way. Let's remove nerve tissue. This is the sphenoid bone. This is how it sits within the skull. So if you look, you can see this. It has, when you look at this bone, you can see it has, we're going to put it in the same position again as if you're looking down on it inside the skull. Here you can see it has lesser wings. It has greater wings that we saw that extending all the way out to the lateral aspect of the skull. Has a very large body. And then it has a very unique thing. This entire area right here is known as the sella turcica. And that literally means Turkish saddle. But there are different parts to this. The Turkish saddle, or the sella turcica, really has 4 different parts. There is what's known as the tuberculum celli, which is right here. If you view this, why is this called a Turkish saddle? Well, if you look, it looks kind of like the saddle of a horse, like you would sit in the saddle of a horse. There is a thing called the tuberculum celli right here at the anterior part. And then here you see the dorsum celli, this little bump on the posterior aspect. This is the dorsum celli, right where the pointer is. Then you can see this depression. This is known as the hypophyseal fossa. This depression right here is the hypophyseal fossa. That's the third part of the sella turcica. That hypophyseal fossa houses the hypophysis, sometimes known as the pituitary gland. Okay? And not uncommon to see, to have someone x-ray the skull, and they'll actually measure this distance. When you measure that, you can determine if there is a hypophyseal tumor or mass, because it will make that space larger. And you can see it on x-ray. You can't see the tumor, but you can see the bone expanding. It's being pushed and made larger because of that tumor. Okay? All right. And then the last part, the fourth part, are these guys, these little bumps, the posterior clinoid process. Okay? All right. Those are the four parts of the sella turcica. So let's exit from there. Very, very important bone, like I said. And it does have what are known as medial and lateral pterygoid plates. You can see them here. We can light this up and I can show you again. If we spin this around here, you see the lateral pterygoid plates and medial pterygoid plates. Very, very interesting bone. Very unique in its shape and its positioning. All right, so let's go back and look at the entire skull for a minute. So we've seen those bones. We should talk about for a minute the zygomatic bone. We mentioned that. And it does have a number of parts. It has a body. Remember, there's a temporal process. There's even a frontal process that we see that goes toward the frontal bone. So there's the zygomatic bone. These are our nasal bones. You see them here. And then the famous maxilla. We have two of them, but they really fuse in the human. The maxilla has what we've already talked about here, the famous infraorbital foramen. There is a nasal spine here on the maxilla as well. You can see this. There's the nasal spine, the anterior nasal spine. And then we also see that it contributes to the orbit. Now, one of the most interesting things is in the maxilla, there is a giant maxillary sinus. And the giant maxillary sinus is really the biggest sinus we have. And this is an interesting scenario. And here's why I say that. If we exit from here and we look back at the skull itself, it's not uncommon for objects to strike the orbit, to strike the eye within the orbit. Things like baseballs and footballs and fists and things like that. And in all honesty, the most common, and these injury, what can happen is in sports we have a certain injury. When something strikes the eye, remember the eye is full of fluid. So you cannot compress fluid inside a closed system. So what happens is, because you cannot compress that fluid, the eye looks for a way out. And what it does is actually break. It creates a fracture of this inferior plate in the orbit and will fracture this part, this maxillary sinus. It actually fractures the superior wall and the eye will herniate down into the maxillary sinus. This is called a blowout fracture. And it's not uncommon at all. In fact, believe it or not, the most common sport you see that this happen in is basketball. And you wouldn't think that, but if you've ever played basketball and you spend any time in the paint, there are lots of elbows flying around. So you see that kind of fracture. Okay? All right. Now, a couple different bones we need to look at. While we're here, let's look at the mandible. The mandible has this foramen. Now, you would think it's called mandibular, but it's not. It's actually called the mental foramen. If we look at the mandible itself, we can see that this is considered its body. It has a ramus, and this part is called the coronoid process. And then there's a notch, sometimes referenced as the mandibular notch. That would make sense. And then there is a mandibular condyle. Now, really important that we look at this. This entire piece of bone, okay, this entire blue area is really called the condylar process. The actual condyle is just the most superior aspect of the condylar process that articulates with the mandibular fossa of the temporal bone. Okay, so we can light this up and we can fade all the other bones, and you can see this would be the condylar process, and the mandibular condyle is actually there, the most superior aspect. Okay, now we want to look at the medial aspect of the mandible. So we're talking about the inside, medial, toward midline. Okay, When we look at the medial aspect of the mandible, you're going to see that there is a bump right here. This bump is known as the lingula, and adjacent to the lingula is the mandibular foramen. Now within that mandibular foramen, there's a little canal. There's a little canal that carries a nerve, and that nerve runs through the ramus and the body of the mandible and exits right there at the mental foramen. So what I might be able to do here is show you this. There you go. This nerve that exits right there is known as, that's the mental foramen. This nerve is the mental nerve. But look at what happens. When we look at how this happens, we see there's a nerve that actually enters. We see that nerve enters the mental foramen. The nerve is known as the inferior alveolar nerve. And then what happens is that inferior alveolar nerve supplies all the dentition and of the lower quadrant of the oral cavity. In other words, that nerve enters, and what it does is actually, I'm going to turn off the nervous system here. That nerve enters, supplies all of these teeth, and then exits as the mental nerve. Okay? So as it does that, dentists typically can go in and palpate, and they palpate for a couple things. One of them is this. They'll palpate for this thing, this phenomandibular ligament, and they also palpate for that lingula. And when they feel those, what they'll do is then inject that area. And what they'll typically do is bathe this area with a sodium channel blocker. Okay? A sodium channel blocker. And so they can bathe that area with a sodium channel blocker and like lidocaine or novocaine, and it will anesthetize all of these teeth, the gingiva, and then it also anesthetizes the area of the mental nerve. And if you've ever had that done, that explains why your inferior labia, your lower lip, and this part of your face actually become anesthetic during that process. You get kind of that droopy little floppy lip. Okay? So very, very interesting scenario or setup there. Okay, any questions on those so far? So we've covered kind of the outside of the skull. We're going to do another video here that covers the more inferior and internal aspect of the skull. Okay, guys, have a great day. I'll talk to you again real soon. Take care.